because we're taking one new technology and looking at the basic supportive science, looking at the clinical evidence and the cost-benefit analysis, so across the board addressing this new therapy using closed-loop spinal cord stimulation and evoked compound action potentials as the marker, the biomarker for efficacy of the stimulation. So I'll start with the basic science, but then you'll really be honored with Jan Willem Kallemard and Peter Statz giving some of the hard data behind the therapy. If I can get the next slide, please. Oh, I've got it. Perfect. So these are my disclosures. I'll wait a minute for everyone to see it. During my presidency of the International Neuromodulation Society and as editor-in-chief of the journal, my conflict of interest requirements are that I gain no income from consulting with industry. Those that you see listed here were all earned before that and have been held in trust since I began that office. So we try to maintain a very strong and forward-facing conflict of interest policy. So I like to keep the marketing hype at a minimum, but I think that there is not only a general misperception, but even a lack of general understanding about what we do with evoked compound action potential monitoring and closed-loop feedback. We know with every pre-existing spinal cord stimulation device that we don't know how much we are activating our target in the spinal cord. Even if we knew exactly what that target was, we have no idea how much our stimulation affects the spinal cord. And that is because the relationship between the electrodes and the spinal cord change in real time due to physical changes like walking, standing, laying down, sitting, twisting, bending, any of those things. As we do that, the relationship between the electrode and the cord change, and what patients experience change. But we have no idea actually how much energy we want to deliver to the spinal cord and how much is actually being delivered to the spinal cord. There are things that are internal to us, physiologic changes, that do the same thing. So for example, coughing, the cardiorespiratory cycle, with sleep deprivation, certainly effects of hydration, all ultimately change this relationship and can have significant differences in terms of how much of the spinal cord gets activated, even when the stimulation parameters are set and maintained. Because the target changes, what the cord sees changes, and we never really know where we are in this dynamic environment. And so the stimulation is both blind, as I just mentioned, but also inconsistent. And unfortunately, to measure is to know. If you can't measure it, you cannot improve it. That's a quote that goes back to Lord Kelvin. But it is true in so many things that if you can't measure it, there's no way for you to optimize it. So regardless of the waveform that we use, whether it's burst or high frequency or anything else, even including tonic stimulation, all of those things suffer from not knowing exactly what it is we are delivering and to what degree. So open loop spinal cord stimulation is that you program the device and it delivers, however you program it, monotonously over time. It can't change to any of those things that we spoke about because those things are inconsistent and not being measured. What this does do is it in part leads to the fact that somewhere around 20% of devices are explanted within the first 2 years of initiating spinal cord stimulation, and that people who are our patients, undergo multiple sessions of reprogramming in order to optimize or at least maintain pain relief in this setting. So while the average is 3 to 4 visits a year, any of you who do spinal cord stimulation know that you have some patients where you get it and they seem to be stable and like it, and other patients who are back in your office every 2 or 3 weeks and maybe 20 times in the course of a year trying to maintain that optimal stimulation. So when we measure evoked compound action potentials, what we are doing is measuring from the outside what the action potential is on the inside. And because we're measuring from multiple cells, we find significant not only the height of the ECAPs, but also the time at which the ECAPs are measured. So if you look on this slide, you can see in the cartoon on the far right, there is stimulation delivered in the blue, and then measured further down the lead are recording contacts on the very same lead that you stimulate with, and those recording contacts are picking up these compound action potentials, which are basically the inverse of an action potential, where there is the initial P1 curve, then the N1 curve, which is is tied to the opening of sodium channels, and then the P2 curve, which is the subsequent opening of the potassium channel, and the distance between the P2 peak and the N1 peak is the amplitude of the evoked compound action potential. What you can do in this system is, because we can measure because we can record as well as stimulate from the same leads, with every stimulation we can measure how much activation of the spinal cord there is, because it correlates directly with the amplitude of the evoked compound action potentials. We can then compare that degree of activation to the degree of activation that was measured in the clinic to determine what the optimal activation of the spinal cord is to provide optimal pain relief. This is a process that initially took an hour, has now been shortened to about 10 minutes, where we measure from the stimulating lead, and what we measure are the evoked compound action potentials, but the system knows what the optimal compound action potential is, which then reflects the volume of activation of the spinal cord. For every single cycle of the system, the amplitude of the stimulation is then adjusted so that the next pulse gives us the optimal amplitude of evoked compound action potentials. So this can occur up to 4 million times a day if you're stimulating at a frequency of 200 hertz, for example. And it's with each and every pulse, which makes it profoundly more granular and profoundly more powerful than doing something every second or two, when we know that these changes in amplitude can occur over the course of milliseconds. So you need that granularity to really follow the physiology of the patient and maintain a proper and consistent amount of activation of the spinal cord. So this is the cartoon around that auto-adjust and feedback mechanism, but this occurs with every single pulse of the device. All other systems, every one of them, lacks this. As a passive system, you program it in and it maintains the output that you have programmed to it. And ECAP's monitoring and closed-loop feedback could theoretically be adapted to every type of stimulation as a way of maintaining consistent feedback, but right now it's limited to the device that has been developed by the Saluda Corporation. If you look at the degree of neural activation, what you can see is that everyone is not the same. If everyone was the same, we probably wouldn't have this problem. But in fact, the amount of activation, the volume of activation of the spinal cord is different from person to person to person. So these are just 3 patients, and this is patient-derived data. This isn't theoretical, but it identifies the fact that people are all over the place in terms of how much stimulation they require to maintain optimal pain relief. And similarly, the patients require the same degree of spinal cord activation regardless of their position. So the changes that we perceive between sitting down, standing up, and laying down are not changes in the need for the degree of volume of activation. In fact, what they are reflecting the changes in position of the spinal cord from the lead. And in fact, if you control for that, as you would with closed-loop stimulation, then you see a very consistent degree of activation of the spinal cord required in each individual patient. To see this graphically, it really hits it home. This is a patient, for example, who's being recorded in the sitting position, who leans back, and in a very short period of time, the amount of stimulation as measured by the microvolts of activation of the spinal cord jump 500-fold. And with that jump, you can imagine that if it was set properly, that's going to bring you into a period where you are above the stimulation threshold, that therapeutic window, and above that therapeutic window is pain. So if someone is getting good stimulation and they lean back, this jump occurs and all of a sudden they're getting shocked. And in older systems, they then reach for their controller and punch the button down until it no longer hurts. The problem with that is twofold. One, patients are pushing on that button 30 or more times a day. They are really dependent on that device, and they're also dependent on paying attention to their pain, which psychologists tell us is a bad thing. If you can get a patient to not pay attention to their pain, they're better off tolerating it. The other problem, of course, is that if you turn it down as a way of avoiding being shocked, you are also turning it down to the point where a significant amount of time you are sub-therapeutic and not getting enough stimulation to make a difference. And so what you see in a non-closed loop population is that once they've been given control of the device, they spend a lot of time in sub-therapeutic stimulation where they can't possibly get pain relief, a lot of time within the therapeutic window, and still a small amount of time in above therapeutic window, which is painful, but that's because they keep turning it down to avoid that. You can see, for example, that the time that these changes take are very short. And that's why this has to be done with every pulse of the system. In this case, for example, a patient coughs. And with the coughing, within a second, their stimulation is 600% higher. And so we need something that can respond to every single pulse of the device as a way of optimizing the stimulation. And so what you see with open loop stimulation is on the top, where patients have a stable amount of output of the system, but a highly varying degree of activation of the spinal cord target, and that's the fixed current that you see below. Absolutely stable, it does what you set it to do, but above you see high variations in the amount of activation of the spinal cord. Compare this to a closed loop stimulation, you see that the activation, the amount of spinal cord activation, the actual activation of our target is rock solid stable. What changes is the amount of stimulation that the device releases in order to maintain that consistency. There are 2 robust studies that have been published that involve this kind of evoked technology. The first is the Avalon study done in Australia, which is a single-arm, multi-center study. It was the first in-human study, 50 patients, 5 sites, and it was a pretty challenging patient population because in the initial pilot studies, the patients that you recruit tend to be the most desperate. But in that study, there was a greater than 80% decrease in the VAS score. Even though these patients, I'm sorry, that's not what I meant to say. The patients started as this difficult population as having a score of 80 or above on a 100-point VAS scale. They'd had about 13 years or more of chronic pain, and about 70% or more of patients who had primary back pain. The high-level evidence randomized controlled trial was the evoked trial performed in the United States. It was a multi-center parallel arm, double-blinded RCT, 36 months of follow-up, 134 randomized patients across 13 sites. Important to recognize that this wasn't against non-ECAPs control. The experimental group was ECAPs measurement, ECAPs programming, and closed-loop stimulation. The comparator arm was open-loop stimulation, but still used ECAPs measurement and ECAPs for optimal programming. A true control group would have been something that did nothing of that, but if you take historical controls, if you take the spinal cord stimulation arms of the 3 immediate prior RCTs that have been done, that is more reflective of a true control population. And in this evoked trial, the study has been published. We'll get more data from that in just a minute from Jan. But the results were published first at 12 months in The Lancet, and second at 24 months recently in JAMA Neurology. So not only a high quality, in fact, the only double-blinded randomized controlled trial in spinal cord stimulation. And this is the flow diagram of patients through the evoked trial. And the primary crossover outcome measure was at 12 months, and then they were followed at 24 and 36 months. It doesn't sound right, but. So if we look at what was measured at the 24-month data, you can see that in the evoked trial, all of these things were used. In the prior 3 large-scale randomized controlled trials, there were varying degrees of adoption of these various measures. And we're pushing, the International Neuromodulation Society, is pushing very strongly that these studies going forward use consistent multiple measures that include the full promise scoring system, and that would be, it's not listed up on the top, but we would like to see all of the outcome measures be multimodal, so we're not just looking at pain, and we would like to see that they look at all of these different areas of potential effect. So we're also performing an ongoing closed-loop study in what we call real-world patients. I'm not sure real-world hasn't been abused to death in the neuromodulation sector, but here we're simply talking about how the stimulation is used in a general clinical environment of neuromodulators. And this study is looking at 300 patients, up to 25 sites in the United States. It is a single-arm feasibility trial. In the real world population, though, meaning that the device is used as physicians will generally use it upon open release of the device, as opposed to with the stringent criteria that a randomized controlled trial demands. And our objectives are to determine the clinical utility of ECAP-derived neurophysiologic measures and outcomes, to really demonstrate firmly how we can use this real-time spinal cord physiology to be able not only to measure and follow in real time, but to use to predict long-term outcomes, predict early any late failures that might occur, although thus far none of the devices from either of the studies have been explanted because of lack of effect. And we'll be using the markers that you see below that. So the key takeaways are that the high explant rates of spinal cord stimulation devices in general, and the high therapy burden that we as clinicians and that company representatives have to maintain the therapy really has an impact both on our patients and the ease of using spinal cord stimulation. And ECAP-controlled closed-loop stimulation automatically adapts in real time, like I said, up to 4 million times a day, but with the granularity that it can correct for any of these physiologic or positional changes before patients even have the awareness of the change. And as a result, it provides consistent and accurate neural activation. So I'd like to have you think of this as an important way to look at real-time spinal cord physiology, determine the degree of spinal cord activation, and that is theoretically applicable to all of the different types and different manufacturers of spinal cord stimulation. And with that, let me ask up Jan Willem Kallewaard, who has been our very busy colleague over here in Europe, who has done some of the closed loop research work and will update us in terms of the clinical implications of closed loop stimulation.